Good morning. My name is Braet. I'm an integrated vascular resident at the University of Michigan, and I'll be talking about contrast-associated acute kidney injury after EVARs. No disclosure. Acute kidney injury after EVAR is common. It occurs up to 18% of elective procedures. It's associated with morbidity, mortality, and ICU admission. And risk factors include preoperative renal insufficiency, medication use such as angiotensin receptor blockers, ACE inhibitors, the contrast dose during the EVAR, and then obviously perioperative complications. To clarify some definitions, I think myself included, but many of us probably normally think about CIN, which is contrast-induced nephropathy. And that refers to an acute kidney injury occurring within 48 hours of IV contrast. However, this definition is problematic because it requires exclusion of other nephrotoxic factors, which just might not be feasible. So in 2015, the American Association of Radiology, or American College of Radiology rather, introduced a new term, contrast-associated acute kidney injury. That really is just any acute kidney injury within 48 hours after IV contrast. It implies that there's a correlation, but it doesn't require exclusion of other nephrotoxic factors. And then they also included this contrast-induced acute kidney injury, which is really the CIN that we classically think of. So that's a subset of patients with contrast-associated AKI that can actually be linked to the IV contrast. So what can we do to prevent our patients from getting contrast-associated AKI? Well, I think it really starts with risk stratification. We need to identify those patients who are at risk. There are some risk calculators that we can use that I'll get into a little bit later. And then there's obviously clinical judgment, identifying those patients who are on medications, who have preoperative renal insufficiency, etc. We can then, once we identify the patients who are at risk, really do some preoperative optimization. Obviously, we can stop those nephrotoxic medications. We can admit them for preoperative hydration prior to the contrast load. And then obviously there are intraoperative considerations as well, using lower isoosmolar contrast, half-dose contrast, using as little amount of contrast as possible, using CO2 contrast, etc. So how about these risk calculators that I talked about? So there are predictive models that do exist for contrast-associated AKI, but as I'll show you in a second, most of them are actually developed and validated for patients undergoing percutaneous cardiac interventions with cardiology. So here's a study out of the Journal of Vascular Surgery in 2020. They had 12 risk calculators that they identified. They excluded 4 of them because they included criteria that were specific to PCIs, such as troponins and PCI time, etc. And here's the 8 they had that they thought could be applicable to EVAR patients. And what we're looking at here is then this AUC, the area under the curve, and this is referring to a C statistic, and a number above 0.7 has good discriminative ability. So basically, a third or half of these were felt to be validated for use in endovascular aneurysm repair. So how about how are we doing in the state of Michigan? So this is a slide, I think, from our 2020 BMC2 meeting from Kathy Stabler. Really what you're looking at here is just comparing U of M to the rest of the BMC2 collaborative. In blue here, we have pre-procedure hydration. Red is postoperative creatinine. Green is preoperative creatinine. And purple is CIN. So if you look at the blue here, you can look at 2019, 2020, and then we don't have quarter 1 of 2021 on this data. You can see that University of Michigan is doing significantly less pre-procedure hydration when compared to the collaborative. Then if you look at the purple as well, there's kind of a corresponding increase in our CIN rates compared to the rest of the collaborative. So if we look at this just with EVAR contrast-associated AKI over time, you can see that U of M here in blue and the collaborative here in yellow. You can see that in 2017, 2019, 2021, we really had higher rates of contrast-associated AKI compared to the rest of the collaborative. So we sought out to generate and validate a pre-procedure prevention algorithm for our elective EVAR patients, just given how the area for improvement at the University of Michigan, and then just the overall need for an actual Prevention Algorithm and Risk Calculator for our EVAR patients, seeing that all of these were done previously for patients undergoing PCI. So just some brief methods. We used the BMC2 and we identified all these EVAR patients. We really just excluded patients who had preoperative renal problems or didn't have creatinine labs that we could look at. We defined a contrast-associated AKI as an increase in creatinine by greater than 0.5. We had some missing data, which we handled via that methodology, and then we used a multivariate analysis to test the associations. We then used those variables to generate a predictive model. This was a machine learning model, and we validated that model within a larger national data set, the Vascular Quality Initiative data set, using similar methods. So here's our BMC2 cohort. We had 7,000 patients. 3.5% had contrast-associated AKI. Majority were male and white, as is typical of our patient population in the state of Michigan. And here are the variables that are associated with contrast-associated AKI after EVAR: increasing age, female gender, GFR less than 30, obviously, current smokers, history of COPD, maximum AAA diameter, and then the presence of an iliac aneurysm. Here's variables during our machine learning model, rather, and here's the variables that are associated with CIN using that model. It's similar overall. I'll point out, kind of hard to read here, but this is the top 15, which is what we use to actually train the model moving forward. But BMI, maximal AAA diameter, age, GFR less than 30, COPD. So very similar here as well, gender, etc. And then here was our final model after doing the machine learning test. So kind of show you here. Down here, we call these the terminal nodes. The yes or no is depicting whether the variable successfully predicted contrast-associated AKI after EVAR. So you can see a couple yeses here, no's, and I'll walk you through this. The number down here is referring to the probability of contrast-associated AKI, and then the percentage is the percentage of sample within the node who actually had contrast-associated AKI after EVAR. So really just looking through this, kind of going top down, patients with a GFR less than 30 is predictive of contrast-associated AKI after EVAR. That's to no surprise. They have less renal function. They're not going to clear that contrast load as well. They're going to be at higher risk. But if we look at patients with GFRs above 30, those are the maximal AAA diameter of above 6.9 will be a higher risk. And then if we look at patients with any maximum AAA diameter, female patients are at greater risk. And so, postulating why this might be with maximum AAA diameter of above 6.9, it might just be a more difficult case, higher contrast load, more runs of contrast, etc., more device parts, etc. And then females, we're really not sure. We're going to run an analysis looking at what might be driving this, but we really are not positive. Maybe smaller overall body size, body area, weight, etc. So higher relative contrast load, if you will. So we then validated this model against the VQI data set. We had 18,000 patients, 5.4% had contrast-associated AKI. So maybe in the state of Michigan, we're doing a little bit better since we had 3.5% when compared to the national sample. And again, a majority were white. And really, we found similar risks using this data set, GFR less than 30, female gender, maximum AAA diameter. So really our next steps is we want to implement a scoring system and really utilize this in real time to identify patients who might need preoperative hydration and or CO2 contrast rather than iodinated contrast. And this might require nursing, maybe we'll work this into the pre-op clinic visits. This maybe might be a MyChart, automated pop-up. We're not really sure exactly how we're going to implement this yet. And then I think really the most interesting thing is tracking this prospectively to see if we implement this protocol, if it actually is going to help our rates of contrast-associated AKI. Here's an example from Dr. Gurm's group in the cardiology. I think they're actually using this for PCIs, and this was kind of what we modeled our study after. This was done using BMC2 data. So if you click this link, it's hard to read here, but you have a lot of variables that you put in here, and then it gives you a numeric percentage of risk. And then they use this based on, so if you're above 7% risk based on this calculator, then they use this algorithm based on your cardiac function to decide how much fluids you're going to give. So this is kind of what we envision. Obviously, our thing on the right here would be more simple, it'd just be 3 factors. But this is kind of what we're envisioning our risk calculator, risk algorithm to look like in the funnel form. So with that, I'd just like to thank Jeremy Albright. He kind of led the stats on this, and then the 2 senior mentors on this, Dr. Osborne and Audrey. And happy to take any questions. Sorry I couldn't be there in person with you all today. Feel free to shoot me an email, and I'm happy to answer any questions via email when I'm able to get to it. Thank you.